I'm definitely not going to take up watching football. Okay, acute valve disease. It's a really difficult talk to give this because there's no evidence really for anything we do in acute valve disease. And still, it is worth taking a look at the guidelines, and when I finish my talk I'll take you back to the guidelines a little bit. These are the 3 guidelines where you might find stuff that's useful. And if you're interested in valve disease on the right side of the heart, the congenital heart disease does include the pulmonary valve, endocarditis of course, and then the latest guidelines on valvular heart disease. I think there are new endocarditis guidelines coming out next year. So the strengths are there's something there, the limitations are that they're evidence-based and there's no evidence for what we do, so there isn't much in there really for us in the acute setting. Why is then critical care valvular heart disease different? I think firstly, the presentations for our patients are really atypical quite frequently when they find themselves on the ICU, and I'll show you some. The clinical findings, even in really extreme valve disease, can be subtle and they can be very, very atypical. It's not the stuff that we learn about when we're doing our sort of usual cardiology training. There is limited ability. Now we have the heart team and we have the MDT, and you get your CT scanning and your MRI and your stress testing. We can't really do that in the critical care setting. Echocardiography can be really misleading, so that's a bit of a problem. And then your risk-benefit ratio for your patients when you're going to intervene is highly skewed. It is not the same as you would see in your outpatient setting. So these are my key considerations. I've given you 2 pictures here. One is very obvious. So this is aortic valve endocarditis. This is aspergillus endocarditis. It's not something you want to see in your patient. So that sort of valve disease with aortic valve disease is obvious, isn't it? You do your echo and there it is. We do need to remember there are 5 valves in the heart. This is eustachian valve endocarditis. When you're doing your transesophageal echo, make sure you take a look at the eustachian valve. And the one that causes me the biggest challenge really is mitral valve disease. And mitral valve disease in the acute setting, I think there are 3 areas to consider. So it can be static and severe, and there are some pitfalls in diagnostics. It can be dynamic, and it can stop you weaning your patient from the ventilator, and you need to be mindful of that. And it can also be very mild in terms of its volume, but really limiting in terms of cardiac output. So I'm going to focus on those really. Okay, so I'm going to start with a clinical case. So this is a real patient. He is 26, he's now 27, and he was diagnosed with pneumonia. There's his X-ray, there is his CT, and he was referred through our severe acute respiratory failure service with so-called pneumonia. And there's no doubt that he did have pneumonia. And they'd done an echo at some point and they said, oh, his left ventricular function is really good. So he comes over and he earns himself VV ECMO. And this is his echocardiogram. So I think they weren't wrong. His LV function, on eyeballing it, is not bad. I mean, you put colour on it, it's really not terribly exciting. But if you look at his forward transmitral velocities, they're really, really high. And I think they were misled in thinking that this was mild mitral regurgitation because they relied on parameters that were misleading, and their apical 40 MPV didn't really help very much. When we did a transesophageal echo, this is what was wrong with his mitral valve. So a patient who has a very abnormal chest radiograph, so-called pneumonia, good left ventricular function, be careful. Unless the imaging is absolutely perfect, make sure you do a quick transesophageal echo, and make sure you don't let your juniors in particular rely on colour Doppler to diagnose in the critically ill setting. Make sure you use your pulse wave and continuous wave Doppler. That would be my first thing. Okay, now I have another clinical case. This man was 32 years old. He again was diagnosed with pneumonia. He again was referred to an ECMO service because he didn't respond. And his past medical history was he'd had a mitral valve replacement. And they said, oh, his LV function is good. So my first red flag in that is that anybody who has good left ventricular function after a mitral valve replacement, really? Is it really good? And then the second was you've got the diagnosis from the parasternal long axis view. So this M mode, mostly people don't use M mode much anymore. I use it a lot in the ICU because the resolution is very good. Temporal resolution is excellent, and even if you can't get good 2D images, usually you can get good M mode. So he has what looks like a very dynamic LV. It sort of fills very rapidly, and he has normalization of the septal motion. So this should be after a mitral valve replacement. It should be paradoxical, and it's not. So the first thing you think of, this man has a paraprosthetic leak. Of course he does. There can't be any other reason. And there you can see he's got a paraprosthetic leak here. So he needed a mitral valve operation. He didn't need VV ECMO. So lesson 1, use Doppler. Lesson 2, don't forget using M mode. It's very, very useful. Okay. Lesson 3, always interpret your LV function in context. This patient, somebody put on VA ECMO, so you can see the aortic valve isn't opening at all. You can see stasis in the root, and they did it because they had severe right ventricular dysfunction and they had severe respiratory failure. What they'd missed on their echo was the reason the patient had what looked like very good left ventricular function. The reason the gas exchange was poor was actually they had a profound RV infarction, and it involved the papillary muscle, and they had severe mitral regurgitation. And that was all missed. They didn't use the evidence that was in front of them. So if you see severe acute respiratory failure and a good left ventricle and a bad right ventricle, you have to ask yourself, why does the left ventricle look good? Is it because it's being offloaded? That may be a VSD, it may be mitral regurgitation, and in this case it was mitral regurgitation. So always use all of the information. And then Guido showed us really nicely the day before yesterday about transmitral Doppler saying isolated A-wave filling. And this is not about severe mitral regurgitation, because all those other cases were severe. This is about mild mitral regurgitation being really important, either limiting your filling or a sign that something isn't right. So here you've got, this is a phonocardiogram, this is an ECG. You can see the heart sounds here. This is isolated A-wave filling, so there's nothing here in early diastole. Here is your mitral regurgitation. It's about 400 milliseconds in duration, which is really, really long. There's no time for filling at all. And you can see that the mitral regurgitation goes right up to almost the P wave. And this is a patient that is ischemic. You've got marked post-ejection shortening here. So what is happening is during diastole, where the LV is supposed to be relaxing in early diastole and allowing transmitral filling, what it's doing is it's continuing to contract. So it's continuing to generate tension, and that means that your LV diastolic pressure in early diastole is too high. So you don't see any flow across the mitral valve. You only see flow across the mitral valve when the atrium contracts. So if your LV continues to generate tension, which you can see here on your M mode, and you have long mitral regurgitation, you have isolated A-wave filling, that's ischemia, so you need to go to the cath lab, or it can be related to bundle branch block, but here it is clearly ischemia. So systole starts at the right time, it's just very, very prolonged. So mild mitral regurgitation can be important in your patient, and you may see this only when you try to wean the patient. So take a look at it. There are other times where the duration of mitral regurgitation can be really important as well. So please focus on the CW Doppler on the right. Okay, so here it's a transesophageal echo, and you've got QRS, QRS, QRS. You've got a short RR interval, and you can see that there is no time for mitral filling here. And if you have very, very rapid heart rate in a patient with slightly prolonged mitral regurgitation, you won't see any filling at all. And that's the reason that you get your apical radial differences in atrial fibrillation. It's because when you have a short RR interval, you've got no time for filling. If you see that in a patient with a limited cardiac output, that may be one of the few occasions where you choose to slow the patient down. One of the very, very few. We talked about chronotropy mismatch. We talked about, well, why would you slow this patient down with either digoxin or ivabradine? This patient, if you saw this a lot, and every time you tried to wean the patient, they go into pulmonary edema, they drop their cardiac output, yes, this is the sort of patient where you might want to slow them down. And this patient is another patient with Actually, this patient had aortic root endocarditis. You can see it there. There's a root abscess. And this patient has pre-systolic mitral regurgitation. And when you see that, that's an important sign to see in your patient. So you go looking for your complete heart block. Actually, your P wave is here. Here is your A wave on your transmitral filling, and you've got very, very long mitral regurgitation. That can do two things. One, it signals that you may have a root abscess, your long PR interval. You may get a high degree of AV block, so look for that. But second, it may also limit cardiac output. So two cases where mitral regurgitation here is mild, but actually very important when you notice it on your echocardiogram. And then finally, what about failure to wean from ventilation? Mitral regurgitation can be reduced quite significantly by about 2 grades or 2.5 grades during positive pressure ventilation. It's a very good treatment for mitral regurgitation. So if you have a patient who is repeatedly failing to wean from ventilation, you have to ask yourself why. Is it respiratory or is it cardiac? This is a lady who came in to a district general hospital with pneumonia. They tried to wean her from the ventilator, she wouldn't wean, and they tried 3 times to wean her. Eventually they got her off, then she was readmitted a couple of months later, and eventually she found her way to our hospital, and she had a TTE which was really unexciting. And we tried to do a focused TTE on weaning, but she became too dyspneic, and she developed bilateral B lines everywhere. You just couldn't see anything. So we did what is less than best. We didn't do a physiological stress, we did a pharmacological stress, and there are 2 types of pharmacological stress that you may want to do on your ICU. One is when you suspect ischemia, when you'll do a standard stress test just like you would in the echo outpatient department. So you use dobutamine, you may add on some atropine, you do a 12-lead ECG, and you're looking for ischemia. The second is when you have dynamic mitral regurgitation. So you don't, unless you think it's ischemic, which is extraordinarily rare to have inducible ischemia causing mitral regurgitation. If it is that you have very little coaptation, which you can see here, so she has atrial dilatation, but it's in the supra-inferior dimension, not annular dilatation, but there's very little coaptation of these mitral valve leaflets. So if you see that in your patient and they fail to wean, suspect that they may have the possibility to have dynamic MR. All we did with this lady, she had a systolic of about 90 at this point. We gave her a little bit of metaraminol and some volume, and we gave her about 250 mils. We got her systolic blood pressure up to about 100, 110, and she developed severe mitral regurgitation. It's quite difficult. Once you start seeing this, and if you do that kind of stress, always make sure that you've got a dilator available, because the MR can get more and more severe, and it's quite difficult to wind back from. So what this lady needed actually was a mitral valve repair. So she had an annuloplasty ring, and she weaned very, very rapidly. So dynamic mitral regurgitation is a thing, and make sure you go looking for it. And just in case you wondered how severe it was, this is her MR at rest, and this is her MR. You can see she's begun to get quite arrhythmic as well. This is her very severe mitral regurgitation on stress. So look for dynamic mitral regurgitation. So that's mitral valve disease. Aortic valve disease is usually easier. It's very obvious when you've got critical aortic stenosis, and that's a problem. All the standard parameters for low flow aortic stenosis and ventricular impairment, they all do apply in the critical care setting. The opportunity to intervene on these patients, though, which you will discuss in an MDT or a heart failure MDT, largely now, it used to be if you have critical aortic stenosis and the patient's very sick, think about balloon aortic valvuloplasty. The pendulum now is going very much towards going straight for a transcatheter aortic valve implant, because BAV is not very satisfactory in a large number of patients. If you do that, then you have to go looking for complications. So if your patient isn't good after your BAV, this is a very early TAVI, you can see what we've done is we've managed to crush all of this calcium up and cause left main stem stenosis. So if your patient comes back from their transcatheter intervention, make sure that you're aware of all the complications that can happen and what are you going to do about it. So she underwent a successful angioplasty to her left main immediately after her procedure. So that was aortic stenosis. So think BAV, think TAVI. Then the other thing about valve disease, similar to mitral valve disease, even mild regurgitation can be important, and it becomes particularly important when you're starting thinking about mechanical circulatory support. So when you're assessing your patient that may need assistance, mild aortic regurgitation such as this, if the heart stops ejecting, then becomes important. And you can see you've got continuous aortic regurgitation. That will be associated with LV dilatation. You have to vent the left ventricle. So mild aortic regurgitation for this kind of patient is important. And then when talking again about mechanical circulatory support, it is really difficult to assess the heart in a patient on an impeller device because it ruins all your Doppler images. And it's also very, very difficult to see colour on a TTE with an impeller device in. So this is a patient where the impeller has become displaced. Here's your mitral valve. The impeller is way, way too close to the aortic valve. If you look on colour, you can't see anything at all, so you can't see any mitral regurgitation, but you can see that you've got pulmonary edema, so everywhere you look in the lungs, you've got pulmonary edema here. So don't rely for mitral valve disease on colour Doppler if you have an impeller, another tip for valve disease. So that's kind of the things that you need to think about. Mild valve disease can be important. Mitral valve disease very limiting in terms of cardiac output. Aortic valve disease when you're thinking about mechanical support. Traditional parameters for aortic stenosis do apply. Traditional parameters for mitral valve disease when it's severe and acute don't necessarily apply. And now I'm going to give you a real world case just to finish with. So this is a case from about 5-6 months ago, a 58-year-old man. He was referred through our shock service. He's deteriorating and he's got severe MR and he's in a cardiac centre. And they rightly said, they identified he had severe MR and they wanted to know what to do about him. So this is what one of our shock MDTs looks like. So about 20 minutes after we got the call, these are all the people who are on the call. So you've got 13 or 14 consultants. So you've got a mitral valve surgeon, a transcatheter mitral interventionalist, a revasc expert, both surgical and interventional cardiology, critical care and anaesthesia, plus transplant surgery, plus transplant cardiology. So we wanted to make the right decision for this guy. So as we knew, this is the data we got during our MDT. He'd presented with chest pain. He had a posterior STEMI. He was a hypertensive smoker. This is what his angiogram looked like. So he got approximately occluded right coronary, he had an EDP of 27. They tried to stent the right coronary and they weren't able to be successful. He had a bit of a cardiac arrest on the table. They put a balloon pump in, they put him back on the ICU and they did an echocardiogram. And this is the sort of echo that we get sent to us. So somebody's taken their phone and they've videoed the echo that they've got. So the features that matter to me, thinking about valve disease, there's two things here that worry me. So obviously he's ruptured a papillary here, so we're going to need to worry about that. But the other thing is he's got a very, very abnormal aortic valve. This man's 58 years old. And so for when we're planning a strategy for him, his valve disease really matters. No question, he's got severe mitral regurgitation, but he also has mild aortic regurgitation. And I told you, remember, that mild AR matters. Because if we put this man on ECMO, he will stop ejecting, he'll get more and more LV dilatation, his MR will get worse, and we will not help his lungs. So ECMO for him is not, peripheral ECMO is not really an option. And then you can see he's got very, very severe right ventricular dysfunction as well. So this man's in quite a lot of trouble. He's on all of these inotropics. He's on a balloon pump, his gas exchange isn't good, his lactate though at the moment is good, and he's got a liver hit and a renal hit. So using our guidelines, we're going to use our SCAI classification. He's a SCAI E and he's had a cardiac arrest, so he's worse than a D really. He's got multi-organ failure, he's got systemic inflammatory response syndrome, he's got biventricular dysfunction, he's got pulmonary edema, coronary disease and structural heart disease. So that's about as bad as it gets when you've got a patient that you're facing and you've got to fix his valve disease up. Guidelines, as I said at the start, you have to go looking for the bits that help you. They're not sort of up front for acute. But in the 2021 valvular heart disease guidelines, they do talk about transcatheter edge-to-edge repair in patients like this and say it is an option. It's an option. They don't say you should do it, but it is an option. So in our chain of survival in cardiogenic shock, we're going to be intervening either surgically or not. So we have to deal with the coronary disease and we have to deal with mitral valve disease. and we have to think about whether we're going to use mechanical circulatory support to get us out of trouble. And yes, again, the guidelines do help us with that. They say we should think about it. Don't say we should use it, but we should think about it. So this is our shock MDT, so we've got everybody on the recording, and we've got minutes that we record and transcribe. So this was the discussion. So our transplant guy said, well, okay, he smokes a bit, and he's a bit hypertensive, but he's only 58. So he could be transplanted, and in my country, that means then you can be eligible for long-term mechanical circulatory support. So if the heart doesn't recover from whatever we do acutely, actually it doesn't matter because he has options. The aortic valve, this little bit of aortic regurgitation, this bicuspid aortic valve is a problem for us. So we're not going to use VA ECMO. And then our interventional cardiologist chipped in and they said, this is an acute on chronic presentation. He's a few days down the line, but he has right coronary disease, and it may be worth giving another go to try and revascularize the right, because it's very different from left coronary revasc. The surgeons got very excited. They calculated his Euro score at 60. So they got very anxious about that and said, no, we don't want to touch this man. Then we discussed, again, extracorporeal support, what could be used while VA was out. And then we got down to the nuts and bolts. So we could think about an impeller to decompress the LV, but the right ventricle is really bad. And this is, remember, in a different centre where they've not done a lot of impeller, so you don't want to start with this kind of patient. So we decided then, if we can stabilise him on MCS, which is now not ECMO but it's an impeller, then you can think about surgery or a percutaneous intervention. And then even if this isn't perfect, he can then still have a mitral valve replacement should he need it, and of course he's transplant potential. And then on top of everything else that's wrong with him, they had given him levo, which is not a great thing to do acutely, but he's got a high procalcitonin, he's probably infected, so the surgeons really didn't want to touch him. So the decision was that he was going to come back to our hospital and think about a staged approach to revascularize him and fix the mitral. This is what we did. So he ended up with a revascularization to his right coronary artery with impeller support. The next day he wasn't really much better, which was a bit disappointing. So then the Microclip team went and got involved, and they put 2 clips in. You can see the stenting of the right here, you can see the calcification around his aortic valve here, and they've reduced his mitral regurgitation to very, very mild indeed. Let's just go back. So 24 hours later, he's coming down on his pressors, his gas exchange is much better, he's still filtered, he had a sedation hold, and a week later he was transferred back to his referring hospital. At 10 days he was discharged home, and he's now 5.5 months after his event. He's NYHA2, he's got mild MR, and he did okay. Now that's complex decision making around valve disease, but actually the guidelines do help you. It is all in there, but what you need around you is a really good MDT. So these are my take-home messages for valve disease. The guidelines can help us, but you need to know where to look. So go looking for the bits that really matter. The clinical and echo features can be misleading. I showed you many cases where the diagnosis was pneumonia, pneumonia with a good left ventricle, and they don't get better. Always think about mitral valve disease. Think about whether the valve disease is static or dynamic, so always think about dynamic mitral regurgitation as a failure to wean. And even mild mitral regurgitation in particular can be important, and mild aortic regurgitation can be important when you're thinking about mechanical circulatory support. You've got to be really good at echo, or you need somebody who's really good at acute echo, and you absolutely need a great MDT around you to make decisions for these patients. Thank you.